the previous paper was talking about specific use of one class of drugs in a specific population with renal dysfunction. By the way, I understand without diabetes, and I will talk to nephrologist about where does it leave us and at which threshold the SGLT2 should be used. Here, the question was much broader, and maybe I will ask you, Gordon, again. How did you approach that particular question?
Well, there are now lots of different drugs and classes of drugs for treating patients with diabetes. And wouldn't it be nice, we thought, if one could summarize all the evidence for all these drugs and drug classes for treatment of diabetes in terms of its outcome, its effects on outcomes that are important to patients? Wouldn't it be nice to have everything compared to everything else and to not using anything and find out the relative merits of all these treatments? And so we did it. It was a big job, as you can imagine, all the randomized trials of all the drugs, putting them together and comparing them to one another. And that was the motivation. I am quite personally, I played some role in this, obviously not a leadership role, but I'm quite proud of this, that we actually got together and put together a team that could summarize this massive literature.
Gordon, you summarized it, and I believe you summarized it in form of something called network meta-analysis, and I believe that illustrates the concept. Would you spend a few minutes explaining the network meta-analysis to people who may be less familiar with it?
Certainly. I think the figure you have on the screen is very helpful for this. So a traditional meta-analysis would look at a single intervention and a single comparator. And each of the lines, the straight lines that you see here, describe studies where a single drug was compared to a single comparator. So for instance, if you take GLP-1 receptor agonists on the upper left, thank you very much, and compare them to standard treatment, you see that there are a substantial number of paired comparisons. And if you look at the bottom left of the SGLT2 inhibitors, you see as well there is lots of paired comparisons where randomized trials were done looking at SGLT2 inhibitors versus standard treatments. And there's lots of other straight lines for other paired comparisons. The width of those lines tells us the magnitude, the number of patients, the number of studies, the number of patients who were included in those studies. So the thickest line with the most comparators is DPP-4 inhibitors against standard treatment. After that, you have the GLP-1 receptor agonists and the SGLT2 inhibitors. But there's lots of other paired comparisons. And indeed, you see lots of other lines, although they are much thinner, reflecting the fact that there are fewer studies and fewer patients, substantially fewer than in those three paired comparisons. This is what you would call a relatively well-connected network. So you see lots of comparisons. So for instance, if you take GLP-1 receptor agonists, they've been compared not only to standard treatment, but they've been compared to SGLT2 inhibitors. They've been compared to thiazolidones, forgive my pronunciation, and so on. They've been compared to basal insulin. They've been compared to basal bolus insulin, et cetera, et cetera. So there are not only comparisons against standard treatment, although the comparisons at standard treatment dominate things, but there are lots of comparisons of a number of these to a number of other ones. This describes what we call a well-connected network, which makes the better connected network, the more confident we are about our inferences from our network meta-analysis. So this is a nice network in terms of well-connected. And what the enormous advantage of the network meta-analysis is you can combine what we call the direct comparisons, like GLP-1 receptor agonist versus standard treatment, with the indirect comparisons. So for instance, if you take GLP-1 receptor agonists and want to make inferences about its comparison to standard treatment, you can not only look at the direct comparisons, but you can look at the DPP4. And if, for instance, the GLP receptor agonists are better against standard treatment than the DPP4s, you gain additional information about the effects. So one big advantage of the network meta-analysis is that it can, in combining the direct and indirect estimates, we get more information and more accurate and precise estimates of our treatment effect. But an even bigger advantage of the network meta-analysis is that we don't need direct comparisons. So we can use the, so let's look at, say, GLP-1 receptor agonist. What has it not been compared to?
Megalinitis.
Okay, well, you and I have the same pronunciation problems. I'm glad to hear it. Anyway, let's say we wanted to compare GLP-1 receptor antagonist to these metaglutinides, okay? And we don't have any direct comparisons. But both of them have been compared to standard treatment. And so we can say, how do GLP-1 receptor agonists do against standard treatment versus the meglitinides? And if, for instance, as is the case, I'm sure, the GLP-1 receptors have a mortality reduction against standard treatment, but the meglitinides do not, one can infer that the GLP-1 receptors are better than the meglitinides in terms of reducing mortality. So we have a great additional advantage of the network meta-analysis is that it allows us to make comparisons between interventions that have never been directly compared through the indirect comparisons. So we can combine the direct and the indirect and gain statistical power by doing that. And we can also make inferences about the relative merits through the indirect comparisons of treatments that have never been compared directly.
Okay, one question here, because all those lines are there for direct comparisons.
That's right. Each of the lines you see. Yes.
What is missing could be construed as indirect comparison. The issue of standard treatment, I take it would be for any particular study, the standard treatment not including the comparator. That's probably how it could be described.
Yes.
So at some stage.
And standard treatment differed over time.
Right.
And circumstances and judgment. So the standard, so one of the assumptions or perhaps limitations of this network meta-analysis is differences in the standard treatment over time and across studies.
Right.
But we decided, and I think wisely, that since previous standard treatments did not have, and no matter what you used, you did not have any effect on major cardiovascular and renal events. So it didn't much matter for those outcomes what the standard treatment was. It didn't do any good. So that is one reason why it is reassuring or legitimate to use standard treatment as a comparator, even if the standard treatment differs across studies.
Okay. So you compared everything to everything. You looked at, I presume, major cardiovascular and renal outcomes. And I think, if you don't mind, I will go to table of results.
Yes.
Would you take us through it?
We love this table, and I'll All modesty aside, I helped to develop these tables. And what they do is a beautiful thing, in my view. They color code to show you what the best treatments are and intermediate treatments and not so good treatments. So, and you can see the gray and you can see the colored. The colored are where we have high or moderate certainty evidence, and the gray are where we have only low or very low quality evidence. So right, the first thing you can look is color is where we have more trustworthy estimates, and the gray are when we have less trustworthy estimates. And then the next thing is the darker, the better. So the dark green are the ones that are among the best, and the lighter green where we have higher moderate certainty evidence, and the lighter green are the ones that are still good, but they're not among the best. So looking at this, you can immediately see that there are two classes of drugs with respect to these major mortal and morbid events that are where the real action is. And those are SGLT2 inhibitors and GLP-1 receptor agonists. And looking at this table, it just jumps out at you that that's where the dark green is, which means number one among the best, and number two, the high or moderate certainty evidence.
So if I can go through the rest of this table, the greens are clearly concentrated in those two. Interestingly, the new class of drugs, non-steroidal mineralocorticosteroid receptor, are also on the greenish side, which is of interest. But there are also, so one would, looking at this, say, okay, these two stand out. Maybe in people who have renal failure or heart failure, the SGLT2 are darker or greener. And among people who have non-fatal stroke, the GLP-1 are darker or more green, deeper greens, which would indicate maybe that could be the preferred class. But there are also side effects, and I wonder to what degree those, there is a fairly dramatic cutting down on those important outcomes, all-cause death, cardiovascular death, non-fatal myocardial infarction. Heart failure is cut down by 1/3, end-stage kidney disease by 40%. I mean, these are fairly dramatic changes. How about the other side? Because there is quite a bit of colors here as well on the arm.
As a matter of fact, we have high certainty evidence about a major relative increase. And remember, we've talked earlier in our conversation how what patients are really interested is absolute effects. And in this table, we only see relative effects. So we would have to go back to our baseline risk to see how serious the problem is. But you can see genital infections happen a lot, but they're not that serious. So if you know your all-cause death is going, if you're at high risk of mortality and your all-cause death is going down substantially, and your cardiovascular death, and you also happen to have are at risk of end-stage kidney disease, where the relative effect, as you've just pointed out, is almost a 40% relative risk reduction, you're probably ready to say, okay, avoiding those things are much more important than avoiding a genital infection. And even though there's an appreciable absolute increase in genital infections, you will go along with it. Amputations, it's a small increase in relative effect, and amputations are rare. So the absolute increase in amputation is pretty nasty, but the absolute increase The relative increase is small, the baseline risk is low, so that doesn't happen too much. Ketoacidosis, unfortunately, incidence pretty low, doubling the risk, but once again, ketoacidosis can be easily treated. So, and I could go through all the outcomes in this, and for SGLT2 inhibitors and GLP-1 receptor agonists, those adverse effects are either relatively uncommon and other than perhaps amputation, things that can be easily managed. So although, yes, those adverse effects are there, relative to the importance of the benefits that patients gain, they're not that compelling, at least to me.
If I could add from the previous paper we were talking about SGLT2, they looked at the genital infection, and the increase was in absolute terms about 27 per thousand. The DKA was 4 per thousand per 5 years, actually. So fairly uncommon, but something to clearly keep in mind. And in those previous meta-analysis, the lower limb amputation, the estimate was 2 per thousand per 5 years. And it was actually not statistically significant. Here you are on the border of statistical significance. So maybe there was 1 or 2 more studies added either here or there to switch it from crossing the threshold of no difference to not. But let me look through this whole table, and please try to convince me that the changes in the overall strategies of management are not as profound as start with one of those 2 drugs and use the other if you need it. I mean, all the others are gray. What's in your mind, and I will ask this question to endocrinologists as well, or people specializing in diabetes, what is the place of all these other drugs, which are very commonly used, metformin, sulfonylureas, basal insulin, bolus insulin? What's your take on it?
Well, we had a long time when we were treating diabetes where nothing, except for maybe the ACE inhibitors in proteinuria, nothing influenced the major outcomes, the major cardiovascular outcomes or renal outcomes, nothing. And so we were giving these things out to lower blood glucose without any impact on the major cardiovascular or renal events. And that's what these results show. When we put it all together, there's still no benefit from these things. Now, on the other hand, there could be, I think there is a reason for lowering blood glucose. The reason for lowering blood glucose is not to prevent these major events. Lowering blood glucose, as far as we can tell, does not prevent the major events. On the other hand, we do see people coming in with hyperosmolar, very sick. They may be extremely sick. They're at risk of dying. And that's because they've got glycosuria and they get volume deplete and they end up in these hyperosmolar states. It may be that the glycosuria also predisposes to urinary tract infections. So there are reasons for lowering the blood glucose. And the SGLT2 inhibitors in particular are not very good. They're about the worst we have of the things we give out in terms of lowering blood glucose. So you're certainly not going to give these drugs out, the other drugs out for lowering for major events, but you may be thinking of giving them for lowering the blood glucose. And take somebody who is young, relatively young, type 2 diabetic, say they're 50 years old and they don't have hypertension and they have no other risk factors, but they're subject to urinary tract infections and they don't like running to the washroom every 15 minutes because of their glycosuria. metformin might be the right drug to start with in such individuals. So anyway, the bottom line is I wouldn't throw them out, but just realize that you're giving them for one and only one reason, is to lower the blood glucose and the possible issues specific to lowering blood glucose, which isn't preventing the major events.
All right. Well, your views are explained, and I hope they will be of use to our listeners. They are to me. I reserve the final judgment to next two recordings with endocrinologists and nephrologists. But in the meantime, I want to thank you for combining and putting this evidence together. I think it was a gigantic work. I'm not sure how you accomplished looking through those thousands of papers and combining them this way. But from the user perspective, I want to thank you for it.
Well, as I said, particularly that network meta-analysis of all the diabetes drugs, which we are now have turned into, it's my Chinese colleagues who are leading that, and particularly a guy named Shi Li. It's now a living network meta-analysis. So,
and where can we find it?
Well, we'll update it. You will find it when enough changes that there are messages. We will put it out and you will find it. And hopefully, once again, the BMJ will publish it. I suspect they will.
Well, Gordon, thank you very much. And thank you for giving us your time and expertise.
It's been a pleasure, Rob.